Okay, so we're live on Zoom. I believe in a minute or so we'll be live on Zoom. All right, so my name is Dr. Ayi. I'm an infectious disease doctor and the president of Ghana Physicians and Surgeons Foundation. So Ghana Physicians and Surgeons Foundation, I tell people to say just Ghana Physicians because it's quite a mouthful. It's an organization that was formed 20 years ago. Next year will be 20 years with the intent of helping to support the Ghana College of Physicians and Surgeons. And so our main focus has been educational, and to find faculty to support the work in Ghana. And we work very closely with our colleagues in Ghana to get this done. In fact, every year at an annual conference, we have the rector of the Ghana College of Physicians come and give a report. And so we try to be relevant to our Ghanaian community and do things that will let them know that they're not living abroad or even in Ghana in isolation, but as doctors, we really, really care about them. And so for the month of October, being Breast Cancer Awareness Month, we just decided to go pink, just to remind ourselves that we have breast cancer is an issue. And so I reached out to Dr. Barbara Enchua, who is many years my senior from Wesley Girls High School and also medical school, who is a family practice physician, and I will introduce her in a moment. And I also reached out to Dr. David Osafo, who is an oncologist, and I'll also be introducing him in a moment. Even though he's not a breast oncologist, I think he would have great expertise. So just a background to this topic and why we decided to look into it. You know, I will mention names, but one of my good friends, my age mates, from primary school, recently confided in me. You know, I've been wondering how she was doing, and she said, you know, Bertha, I just finished treatment for breast cancer. Then there was a friend of mine who we played together in primary school, and somehow one day I just thought, you know, I haven't heard of this lady in 40 years. Let me check on her on Facebook. And I went on there and it was rest in peace, rest in peace. So I contacted one of those who were doing RIP, and they told me, oh, your friend, she died from breast cancer 4 years ago. So that's just one of many. And the more we look into it, we realize that in the past, maybe breast cancer may have been like a stigma. Oh, hush, hush, let's hide it. You know, don't let anybody know that you have cancer. But we can't hide from it because in the US, 1 in 8 women will be diagnosed with breast cancer. And in Ghana, and among the Black population, it's actually 1 in 5. So if you walk past 10 women, 2 of them may have had breast cancer or they will develop breast cancer. And we found out that if breast cancer is diagnosed at stage 0, the survival is 100%. In fact, nobody needs to die from breast cancer unless you find the lump, which we'll be talking about, and the signs and the symptoms. So if we say we're really fighting, then we've got to take action. Fight is not in the pink colors we wear. It's not in just saying I support breast cancer. It's not just in a donation to research, but that you will take the right decisions. Your friend will take the right decisions. Spouses who touch females' breasts will be able to tell, oh, I think my wife should be evaluated because I found something abnormal, and I feel empowered because I know what breast cancer should look like. And as a matter of fact, just today, I was talking with somebody who had helped with a breast screening exercise at a church. I mean, for confidentiality reasons, I won't mention the name of the church, but he said out of 100 people that were screened, in fact, they picked about maybe 5 or so, but one of them, he's 100% sure it's breast cancer, which in reality goes with what they find in mammograms, that if you screen 100 women with a mammogram, about 90% of them, you won't find anything. 10 of them, you might find something abnormal and call them back. 2 may go through a biopsy and 1 may have breast cancer. So I'm going to introduce our speakers, and thank you all for making the time to be with us this evening. So Dr. Barbara Incha, who is going to be our first speaker, is a board-certified family medicine physician with a master's in community nutrition. She's a fellow of the Ghana College of Physicians and Surgeons and currently works as a physician in primary care in Florida. She's the vice president of a nonprofit organization called Gateway of Hope, which has been serving people in Ghana through free medical clinics, community health education, sexual health education in schools, and writing of health articles for newspapers and social media. She's been so influential that her year group elected her as one of the most impactful people who graduated medicine with them. She's organized health fairs, the latest on breast and cervical cancer, which will be an annual event. It just ended on October 15th, so she's hugely relevant. Her organization has a free kindergarten through junior high school in the eastern region of Ghana for underprivileged children. She's the author of 4 books. The latest is A Woman's Guide to Her Body and Total Health, released in 2021. In fact, she sent me a copy, and that book, believe you me, is about 2 inches thick. I looked at it and I thought, you know what? This is no handbook. This is a textbook. How she managed to keep everything in medicine inside that book beats my mind, but it tells the kind of person she is, a true person of quality who wants to empower women to take charge of their health. And she will showcase a copy of the book and how to get hold of it. I think if you're a woman, you should keep it on your shelf. In fact, I have had to refer to it a couple of times when I was figuring out some things on menopause. And her answer was right on. I was told that use oil of evening primrose, and I thought, will it be in Dr. Barbara's book? And sure enough, it was in her book. Our second speaker is Dr. David Osafo. And David is going to be joining us, but he's also driving at the same time. So he's going to be a good backup resource for us. And I'll give him kudos because he was the first person to put on pink and take pictures for GPSF. I was hoping a woman would do it, but he beat all the women and he dressed up and he said, it doesn't make me any less of a man. So Dr. Sapo went to Achimota School, graduating in 1986 for O-level and for A-level 1988. He attended School of Medical Sciences in Komfo-Anokye Teaching Hospital, completing in 1995. And then he was a medical officer for a while. He left to the United Kingdom, working in the Royal Devon and Exeter NHS Trust. And then he proceeded to Cook County Hospital in Chicago for internal medicine residency. He then continued with a hematology oncology fellowship from 2000 to 2006 and is currently a multi-specialty practice in Ruston, Louisiana. So without much ado, please help me welcome our 2 speakers. Dr. Barbara, you have the floor.
Okay, share screen. Hi, everybody. I'm trying to share my screen. Yeah. Okay, so there, and I have to come. My daughter is helping me here. Well, I'm really delighted to be here and to be part of okay. Can everybody see the screen? Can you all see the screen?
Yes, please.
Okay, great.
But it's not in a slide presentation mode. It's in view mode. Yeah. So slideshow.
It should be now, right?
Now, yes, okay. Yes, please.
Okay, my daughter is here helping me. So I'm delighted to be here and to be part of this. And I hope that by the end of our presentations and the whole thing, you would also have questions to ask, and we will have a knowledgeable time together here. So what I'm going to discuss, just an overview, is what is breast cancer, what types do we have, what's the extent of the problem in Ghana and in developed countries like US and UK, and then some of the risk factors, what we can do. I believe very much in preventive medicine, preventive health, and us taking control of our own health. And that means that there are certain responsibilities that we have to stand up and assume. And so we'll talk about some of those: prevention of breast cancer, screening, treatment. I would leave to Dr. David to take care of that, but I'll kind of answer and have a few slides just briefly on that, and then if there are any questions and answers. And so let's roll on. My screen is very pale. So what is breast cancer? Breast cancer is abnormal breast cells that are growing very rapidly in the breast. Breast cancer is mostly in women, as we know, although men have it, but it's very rare. And with that abnormal fast growth of these cells, we end up with maybe a mass or a lump or a tumor. They all are interchangeable. We can use that as interchangeable. And the cells can be localized, or they can travel to the lymph nodes under your armpit or just above your collarbone or below your collarbone. And then they can also spread. Now, there are two main areas where breast cancer occurs in the breast. It can be localized to the ducts. And let me see if I have a slide of the breast. Yeah, okay. Okay. There are two main types. There's lobular cancer, and then there's ductal cancer. Now, if you look at the screen on my right, I don't know if it's your left, you will see a picture of a breast, you know, just a diagram, and you find out that the breast contains various organs, and you have the muscle, which is close to the chest wall. You have a lot of fat cells, and when you become postmenopausal, most of the breast becomes fatty. And then you also have the lobules. Lobules is where the milk is produced, and then when it's produced, it goes through the ducts that you can see, and it comes out through the nipple for a baby to nurse on. And so you can have the breast cancer either in the ducts or in the lobules, okay? And like I said, the ducts are the small channels through which milk passes. Now, breast cancer can be localized, you know, and that means it's localized at the point where it started. So if it started in the ducts, then we call it in situ. Breast cancer in situ or in situ. We normally say in situ over here. And so it is localized over there. And then it can also may start in the lobules and be localized there. It hasn't gone anywhere. Now, when you find that the cells move from where they started and go to other parts of the breast, then we say that it is invasive, okay? So it may move from those parts and go to other parts of the breast. It may even go to the skin area and so on and so forth. And then when it goes beyond the breast, we call it metastatic breast cancer. So those are some of the terminologies that we use. Now let's consider the size of the problem in Ghana. And this is 2020 data. And some of the slides are courtesy of Dr. Owusu, Cynthia Owusu, who put some of them together. So I kind of mixed them my own, and some of them are hers. And this is hers. And this is from data estimating the number of new cases. Somebody needs to be admitted, please. Yeah. And if you look at the pie chart, you see that breast cancer is about 4,500, and cervical cancer is almost 3,000. Breast cancer constitutes about 30% of all cancers in women in Ghana, and cervical cancer is about 20%. And these two, as was mentioned, I'm very passionate about these two, and I'm collaborating with people in Ghana to see how we can get screening for both of these cancers, which people do not need to die from if screening is in place. Okay, so we talked about the number that may be they were anticipating for 2020, and then this is the number of showing total deaths. And see the number, it's about a quarter of people were estimated to die from breast cancer in Ghana, 25% of women amongst all cancer deaths in Ghana. Okay, so breast cancer forms about a quarter, cervical cancer forms about 20%, and then others like colon cancer, liver, and others are in the diagram. Now, this is for the US, and the reason why I had put in this slide is I want you to look at breast cancer in the US. Again, they are about 31% of all new cancer cases. Women have breast cancer about 31% of the time. And on the right, look at the estimate cancer deaths of breast cancer. It's 15%. While in Ghana, we saw that about 50% of people will die from it, within 5 years of diagnosis. And so this shows us the difference. Why the difference? Why? And invariably, one of the main factors is early detection and screening. Because when you detect it early, in the early stages, it can be treated, and there can even be a cure of it. And so this was put in so that people would see the difference in the percentages between a country that does a lot of screening and then one that doesn't. So we're going to look at what are the risk factors for breast cancer. The interesting thing is that there are both modifiable risk factors and then risk factors that are we cannot do anything about it. Okay. And for example, if you've been born a female, you can't do anything about it. Well, at least in most places. So that is quite high among the non-modifiable risk factors. If you're getting older, after the age of 50, you have a lot of things going on in your body, changes in cell, inflammation, and so on and so forth. And so you find out that you tend to get more cancer cases, even generally. And then, of course, that includes breast cancer. And then if you have inherited certain genes, and we'll talk more about that later, if you have a family history of breast cancer, especially in a first-degree relative, and first-degree relative could be your mother, your daughter, okay, your mother and your daughter, or yes, those belong there. Sometimes grandmother is not added to that, but first-degree, like a sister, a mother, and a daughter, you find out that you can have a strong history. And so that is something that every one of us should take very seriously. And we will talk about when, for example, you would start screening as opposed to somebody who just has an average risk. And then, of course, if you have a personal history of breast cancer in one breast, the tendency to have it in either that same breast, if it wasn't removed, or in this other breast is very high. Race, white people tend to have a slight higher incidence of breast cancer compared to Hispanics, Blacks, and Asian people. However, we would see later the fact that in spite of that, they tend to live and be cured of breast cancer more than the other groups. Then there's something called dense breast tissue. This is when I showed you how the breast has fatty tissue. It has the lobules, and then it has the ducts. There's also what we call connective tissue in between the cells. And when you have a lot of that, your breast is described as being dense. And so that is seen on mammograms. And when you have dense breasts, then the radiologist has some things that they may want to do, more studies to make sure that there is not a mass hiding behind the dense breast tissue. And then having certain benign conditions, which I'll mention later. And then if you start having your menses or menarche, as we call it, very early, or you go through menopause after the age of 55, you've had quite a bit of time where you have been exposed to female hormones. And so you may have a higher risk factor of getting breast cancer. And then if you've had radiation to your chest for anything, any other condition, disease, even people who have had thyroid cancer and had some radiation and so on. And then if you have a family history of ovarian cancer. Now the modifiable risk factors, that's what I want us to concentrate on. The ones on the left, we can't do much about it. You know, that is how it is. But there are modifiable risk factors which you and I can now start doing if we are not already doing that. And that includes decreasing amount of alcohol intake. Women are not supposed to, well, I'll not say are not supposed to, but women really, the limit of alcohol per day is 1 glass of wine, you know, 12 ounces of beer, and about 1 ounce or so of spirit. So when you do more than 2, then you have to modify this risk factor yourself by decreasing the amount of alcohol that you're taking in. And then being overweight or obese, that is a problem we tend to struggle with. But there are ways in which we can take care of those and help decrease that. Sewa and Ikwa, please, can you admit people? It keeps showing up on my screen. Now, if you're not physically active, which is exercise of any sort, whether you are walking, you're going to the gym, I always tell people that walking is the cheapest exercise on earth because you don't pay for it in terms of money. And so if you are physically active, you find out that it is a risk factor. Being not being physically active is a risk factor, but you can modify it by exercising and doing walking, gardening, dancing, whatever you want to do, you can do. If you want to go to the gym, you can do, but just moving really. And then those people who have never had any children, they also are at an increased risk. But well, what would we say? Maybe somebody doesn't want to have children, or if they do, it's best to have it. And then also if you're breastfeeding, it's really good because they believe that sometimes they are not sure of the mechanisms, but they sometimes think that there are kind of two schools of thought, that the breastfeeding, when you are lactating, you may change some of the cells you make the cells more resistant, the cells in the breast more resistant to changes, which would lead to cancer cells. And then also during breastfeeding, you are not menstruating. And so you are not having all those female hormones at high levels. And we know that female hormones, especially estrogens, tend to feed into breast cancer and then make them even worse. And birth control pills, of course, they involve estrogen. And so that's why they are modifiable risk factors. And for example, if somebody is on birth control after the age of 35 and they are a smoker, we take them off birth control pills and then put them on some other form of birth control because they are more prone. Although the whole issue about smoking, some studies say it is a big risk factors, others don't. But when you combine it with taking birth control after the age of 35, then you are at an increased risk. And so we advise people to stop smoking. And of course, when we put people on birth control pill, we want to take a history to make sure that they don't have a family history, a strong family history of breast cancer, and by them, or even by they themselves had breast cancer before. And in that way, we want to keep away from birth control pills, which have estrogen. And then women who are on menopause therapy using hormones. In a big study in 2012, when the results came out, they found out that women, especially above the age of 60, have an increased risk for breast cancer if they were on hormone replacement therapy. And then I mentioned the tobacco use, which I said some studies, it's not some studies think it's not as big as, for example, alcohol. So these are the protective factors that we have already discussed. You know, a healthy diet too, low in fat, increased vegetables and fruits. So those are important because we mentioned how obesity and overweight, because of the fat content, can make you at increased risk to breast cancer. So losing weight or maintaining a healthy weight is important as one of the protective factors against breast cancer. And we mentioned breastfeeding, we mentioned all of that. And they have found out that people who take aspirin or anti-inflammatory drugs, and when we say anti-inflammatory drugs, we are talking about ibuprofen, brufen, naproxen. People who take those drugs tend to have decreased incidence of breast cancer. It kind of protects them against breast cancer. And so, but then you just don't go and start an aspirin without talking to your doctor, or because it can also cause gastritis and stuff like that, bleeding in your GI tract and so on. And anti-inflammatory drugs too, you have to make sure if you, for example, you have kidney disease, we don't want you to take ibuprofen or Motrin or Advil at all. So that also you can't just get up and take, you know. But if, for example, somebody had a strong family history or so, their doctor may advise them to do that, to take an aspirin, a baby aspirin, or some anti-inflammatory drugs, maybe to use that for pain control if you're having pain in any other part of your body, like your joints and so on. And then for those who are high risk to have a high risk for breast cancer, there are some people who, when they do the mammogram, they see some abnormality in the duct, they go and have a biopsy and they realize that they have what we call atypical hyperplasia in the biopsy report. And for people like that, they are put on anti-estrogen drugs as a medicine to prevent that pre-cancer from developing into real cancer. And so that is often used as well if a biopsy come up with that report. And I'm sure some of you are wondering about race, which we've mentioned briefly, that white women have a slight slightly more higher incidence. But unfortunately, we find out that Black women tend to develop more aggressive forms. And not only that, when they get diagnosed, they have more advanced stage breast cancer. And that happens not only in a place like the US, but even in Ghana, we find out that we tend to have certain types of breast cancer that tend to be more aggressive and are not amenable to the usual therapy that is used for treating. And for the US, the only reason is that there's so much socioeconomic factors that play into this, the fact that there are healthcare disparities, the fact that people don't even take care of women of color like they do of white people. Black people may not have health insurance. So many of those socioeconomic factors that affect that. But for in countries where you have like, I mean, the ethnicity is all Black, like in Ghana, for example, our problem is early detection and diagnosis. And then, of course, we also, I'll show in another slide how we tend to have some more aggressive type that is more difficult to treat. So these are some of the symptoms. I'm sure you are all aware and have heard how there may be changes around the nipple. You may have blood coming out of the nipple. You may have something like a ball. In fact, I knew somebody who had something like a ball. It's interesting. One person was in Ghana, one person I went to church with over here. And they told me, the one here, they told me, oh, I have like a ball. I said, let's go into the bathroom. Let me go and look at it and show it to me. So she shows it to me and I said, this is not a boil. This is not a boil, because that person had had an abnormal mammogram some years ago and was told to follow up and she didn't. And so in the end, I begged and, you know, got her going. And when she went, she had stage 4 breast cancer. And this thing, which was there looking like a ball, it was almost about to burst, you know, and it was just poking out through the skin. Of course, some people may just see a lump, may feel a lump in the breast, and there might also be what we call pitting of the breast skin. Some oranges, especially some of them, you see that it looks like it's not smooth, but it's like pitting, like parts have gone in a little bit in the skin. That's what we call pitting. And that is not a good sign, you know, and that has to be most people with breast cancer, diagnosed with breast cancer, don't have pain. Actually, a few people may complain of pain, but most people, pain is not one of the first symptoms that you find. You may get pain if it's about to burst through the skin, like I mentioned, or if it's spread. So screening for breast cancer, we all know that screening mammogram is the gold standard for screening breast cancer. And if you look at some of the rich resource countries, you'll find out that since for the last 25 years, you find that the incidence of breast cancer has gone down, you know, and it's because they are catching them early. They are catching people's breast cancer early, and they are able to get them treated and cured and have a 90% or so 5-year survival rate, which means that at 5 years, 90% of people who had that localized or carcinoma inductor, they are cured. So when do we do mammograms? Different countries differ, but in the US, it's 40, at the age of 40, if you are at average risk. But if you have those risk factors that I mentioned, you may even have to start at about 20. And yours may involve not just a screening mammogram, but it may involve other things, like even an MRI and so on and so forth. We'll talk about that. And so, yes, if you have a high a high risk, and if your lifetime risk is greater than 20%, doctors and actually some of the places where they do the mammograms, they are able to calculate what your risk is, your lifetime risk. Okay, that if you lived up to the age of 90, what will be your risk for developing breast cancer? And that is calculated, and they put in some numbers, family history, your age, when you had, whether you have children, so many other things, and they calculate and put the numbers in and are able to develop a lifetime risk. And if they find out that your lifetime risk is greater than 20%, then you are at high risk. If you have family history, if you've had some genetic mutations, which we'll talk about later, then you'll find that you have to start earlier. And so for those people, they would have not just a plain screening mammogram, but they may have MRI and or ultrasound, or and if they see something in the mammogram, then you will have what we call a diagnostic mammogram. That involves looking at specific areas and doing more of the films. They shoot more of the films. And then the other way of screening is clinical breast exam. This means that you are being examined by a healthcare professional who has been who is trained to do clinical breast exams. And that is often used in Ghana when we are in the month of October, because not everybody can afford to have a mammogram. But clinical breast exam, and I always say that, you know, you as an individual, you can go to your doctor and tell them, can you do a breast exam on me? So I make sure that when I am doing self-breast exam, I know that you have done it first and it looks, you say it's okay. And so I will do it on my own. Other methods used, which are not screening per se, but we call them breast awareness, or we also call it getting to know what your breast feels like. It includes self-breast exam, where you will examine your breast once a month. If you're still menstruating, about a week after your period, the breasts are not tender, they are more soft and so on. And you can do it in the shower or lying down. If you Google, it will show you how you can do it, self-breast exam. But like I said, before you start self-breast exam, make sure that you've gone to a physician or a nurse practitioner or somebody who can do your exam first for you, and then you pick up from there. Now, there are some mobile devices that are being used not to screen for breast cancer, but to augment clinical breast exams or self-breast exams. And I have a picture of a couple of them. These are usually used in a dark room. You stand facing the mirror, and they tend to use infrared light, which is not dangerous. And a couple of them are called Breast Light and Silk Pro Pink Luminous Breast device. And this way you get to know your breast. And so if there's a problem, you can easily recognize that. And then you go and see a doctor about it. These are some of the devices. And when I was in Ghana this month, and we did our breast fair, and we missed most of you anyway, we were using the pink one. And this Silk Pro one on the left, it was used in a study in Puerto Rico. And they found out that it was able to detect masses that mammogram was able to detect, you know, but of course it depends on the size of the mass and so on, location and stuff like that. So it was one that they had written a study report about. And then this other one is the infrared breast device. In some places you can order them on Amazon. You can also get it. Remember, this is just augmenting what you are doing yourself. It's not screening. Mammogram is the thing to go for as the go-to. it's the gold standard, but this does help you in your self breast exam that you can do at home. Diagnosis of breast cancer: when you detect a lump, or you go for yourself, or you go for a mammogram and they detect a lump, what happens is that the radiologists will let you have a diagnostic mammogram, and then it's often combined with an ultrasound. And if they can't see things properly, or if your breast is very dense, you'll find out that they may even ask you to go for an MRI of the breast. And they will do an MRI by doing first an MRI and then giving you some contrast that they will inject, and then they will take another MRI picture and compare the two. And if they realize it's a mass, it's not just a cyst or anything like that, they may want to do a biopsy. And there are two types of biopsy: ultrasound guided biopsy and stereotactic breast biopsy. Ultrasound usually is used when the mass is kind of near the surface, it's not deep. And stereotactic is when it's deep. And in that case, you go into the radiological department usually, and then they use a mammogram, and you lie face down, your breast is hanging, and they have a needle, and they go through and they do that biopsy. Then it's sent to pathology for studies to be on the breast tissue and so on and so forth, to find out what type it is, whether there are certain estrogen receptors on present, or progesterone receptors present in the tissue, and that will help guide the kind of treatments that you would get. But usually, if they do find that it is breast cancer, they would go and do what we call a PET-CT. It's a special type of CT scan, and it checks the whole body to make sure that your breast cancer has not spread to other parts of your body. So I mentioned the receptors briefly, but maybe we'll come to that later because we don't have too much time, I think. But these they are proteins which are on the surface of breast cancer cells, and they fuel the growth of and division of the cells. And so if your breast cancer is found out that you have estrogen, one which is estrogen receptive, or it's an estrogen receptor, then they know how to treat you by giving you anti-estrogens in the course of the treatment after you've done the basic treatment. Yours may be progesterone receptor sensitive, and so they would also, but it's mostly the estrogen one that they really go ahead and they will give you anti-estrogen medicine. So it helps determine treatment options, basically, and which Dr. Osafo will probably talk about. Now, usually we look at breast cancer and say, okay, which of them are hormone positive? That's what I mentioned before. 72% tend to be hormone positive, which means they have these protein receptors on them that are sensitive to estrogen. The estrogen will come and bind to the protein on the surface, and then it will just fuel the cells and they will multiply, or the progesterone will do the same. And so that's what we call hormone positive. And about 72% of breast cancers fall in that category. There's another one called HERS2 positive. This is a genetic kind of mutation that also can cause the breast cancer cells to multiply and divide. And then 15% is triple negative. It means that they didn't find any HERS2, they didn't find any progesterone, or they didn't find any estrogen receptors on the cancer cells. And this is the proportion of Ghanaian women with the triple negative breast cancer. In fact, in a study done, I think in the 90s in Kumasi, an African-American lady had gone to do some studies there, and she found the same thing that, which this study, which was done in 2010, also found. They just took white Americans, African-Americans, and Ghanaian women, and they wanted to see the percentage of triple negative breast cancer, and these were the ratios. The number of Ghanaians were small, though, 75, but you see that about 83% of them had triple negative, and those are the hard ones to treat. So this is where Dr. Osafo comes in, but you know, depending on the size of the breast cancer, whether it's localized, whether it's invasive, whether it's metastatic, you can have different types of treatments. And I just threw this in so that many people hear about chemo, but there's radiation which may be given before even surgery to kind of shrink the tissue a little bit and so on. And surgical hormonal therapy was what I discussed about the hormone receptors. And then there's immunotherapy and targeted therapy. These two, the immunotherapy and targeted cancer therapy, where the targeted one, they target the cancer cells. So you don't have things like other cells being affected, like when you have a chemo, which targets all the cells. And this works at the molecular level. And then you have immunotherapy, where your immune system is kind of boosted to fight the breast cancer. I'm not sure whether the last two are being used in Ghana, but you find out that some people who even have metastatic breast cancer in living in resource-rich countries are still alive and living their lives because they've been put on these therapies, which is helping them prolong their lives. So that is it for me. This is my book that I just want to mention in passing before I turn it back to Sewa. It's 650 pages, and I took 3 years to write. COVID wasn't too good to me, so I couldn't launch it early. But the reason why I wrote this book was that as a family medicine physician, I saw women both in Ghana and in the US who come and see me, and they are clueless about their medical conditions. They don't know the names of the medicines they are taking. They don't even know. They would say, they told me I had a little bit of sugar. Meanwhile, the person is diabetic. And so I decided that let me write a book for women to empower women. You know, it's for empowerment, so that before you go and see your doctor about anything, you've already read about something. And me, a doctor, when people come to see me, I love it when they know about their medical conditions and are able to have a meaningful conversation with me. So that's why I wrote this good book. It's not a book that you take and you sit down and you finish reading it. No, you tend to it. You have a sinus infection. Okay, what do I look up and see what I can do myself if I have a sinus infection? I have this. What can I do? My friend has this. So that's basically what it is. So it is in Ghana, and it is also on Amazon. Thank you so much for your attention. And I will turn it over to Dr. Aye. Thank you.
All right. Okay. If you are able to clap, please let's give a clap for Dr. Intua, because yes, she's done so well. I'll tell you what, this woman was in Ghana on October 15th doing breast screening and all that. And then within a week, we asked her to do this, and she's done it so well. She's running a school in Ghana. She has a clinic. She's doing so much for herself. So no wonder her class nominated her as one of the most impactful in their year group. So Dr. Intua, thank you for this wonderful, wonderful presentation. And I tell you, you should get a copy of her book. You should keep it in your home, as I would call it. Barbara says, if somebody tells you to go and chew lemon for something, or they give you anything odd, just look in the book and say, okay, what does Barbara say about this? If you find it, it's probably authentic. So Dr. Barbara Intra, thank you so much for wonderful presentation. So I was going to call Dr. David, but he's told me he's driving. So while waiting to see if he has any comments, there's just something really briefly I prepared and I want to share with all of you. I found it instructive as a doctor because, you know, lobula, dactyla, this inside it can get confusing. So I created this model that shows you a cross-section through the breasts. And I'm going to use really simple examples. We're going to use lemon to represent the yellow things you see. They are the lobules. Now, it's easy to think of an orange being squeezed. So these yellow lobules, that's where the factories where breast milk is made. And then they come through the ducts. So this is just a yogurt bottle. So just think of breast milk being squeezed through ducts, through this bottle, or better still this way, and it comes out. Now, inside this lining, the tubes, you have these cells that, and I'm hoping this was very helpful to me. You have cells that are nicely arranged. You see, this is your body. Inside those tubes that carry the breast milk, you have normal cells. Why are we calling them normal? They look normal. They multiply in a controlled fashion. So if you have these cells like that, when they're supposed to multiply, 1 becomes 2, and then 2 becomes 4. So it's orderly. So imagine somebody who has cancer. This is what's going to happen. Suddenly, these pink cells turn into abnormal cells. Green is obviously different from pink. They look abnormal and they're multiplying uncontrollably. So 2 things we want you to remember, and Dr. Entwa said it. They're abnormal and they're multiplying uncontrollably. And when you have stage 0 breast cancer, this is not invasive. So that green abnormal cell is just sitting inside. It hasn't broken through the duct. Now, this is the stage where a mammogram would pick it up. And at this stage 0 stage, the survival rate is 100%. So I know we think that breast cancer is somebody's cancer. It doesn't run in my family. Now we know that if you're a woman, you are at risk, period. So we've got to be each other's keeper. Stage 0 breast cancer has 100% survival. So one of the things I would want us to explore as we talk about this webinar, whether mammograms are easily accessible in Ghana and how much it costs. I know in the United States, it's paid for by a lot of insurance companies and women get theirs every year. And as a disclaimer, sometimes I had my first mammogram way past my 40s. I was supposed to get it at 40. And after I got it once, I never went back. So this month, it made me sit up that, look, mammograms should start at age 40 and you should do it every year. Now, the guidelines differ according to which organization you're looking at. The radiologists who are reading the mammograms, their guideline is that you should start at age 40 and do it every year. Then the US Preventative Task Force, they say you should still start at age 40 and do it every other year. American College of Physicians, who are very safety conscious, they say that if you do it every year, there's overdiagnosis, overexposure to radiation, and a lot of anxiety. The bottom line for you as a woman is this. Okay, at 40, I should start screening, whether I have risk factors or not, and that I should do it frequently, minimum every year. And the reason is you want to pick it at stage number 0. I want you to keep this in your mind. because if you do this, no one would die from breast cancer. The minute it escapes and it becomes invasive, even if it's 2 centimeters and it hasn't reached the lymph nodes, 2% of women will die. The survival goes to 98%. If it becomes stage 2 or stage 3, the survival is even lower. In fact, if it's metastatic, meaning stage 4, it's gone to the liver, the spleen. No matter what we do, the survival is only 16%. It means 85% of women who would get diagnosed with breast cancer with stage 4, they would die, no matter how much love we pour on them. And so I know Dr. Intwa showed you the signs. I just have something I want to show you real quick. The skin of a woman's breast, it should be as smooth as an apple. When somebody has breast cancer, it changes to what Dr. Intwa called pot orange. And I want you to look at the skin of an orange. It is, I'm using lime in this case. It is very different from the apple, right? You can see little pits. And that's because there's something called the lymphatic system that drains fluid from the breast. When somebody has cancer and it's blocking those lymph nodes, the fluid cannot go. And so the pitted areas is actually the little dimples or little hair follicles. And the area that is looking abnormal is just the extra fluid. So pot orange is French for the skin of an orange. So if you are a man or a woman and you feel your breast and it feels thickened and it's looking like the skin of an orange, you should immediately start thinking breast cancer. The other thing that the oranges or the lime can teach us is that, you see, the nipples look like this on the side view. When somebody has breast cancer, it starts looking like this. It retracts, right? So retracted nipples, which are now looking flat on the side view, should remind you of breast cancer, or if it's bleeding. So those are some of the things that I wanted to just throw in as a moderator. And also, one of the things that shocked me this week was the study that was released from the National Institute of Health that women who used hair straighteners, relaxing, we called it perming when we were growing up, have a 4-fold risk of uterine cancer. They studied 33,000 women. They call it a sister study, sisters of women who had developed breast cancer. They've collected 50,000 women and they're studying them. And out of the 378 women who developed uterine cancer, there was 4-fold risk of the fact that they had used hair relaxing creams. So I sat up and I started reading, and oh my God, apparently the same thing applies to breast cancer. In fact, the Breast Cancer Association was even found a long time ago. Breast cancer, fibroids, fibrocystic disease of the breasts, and you name it. And what was even concerning was that I didn't know that research right here in Ghana, they've been studying women with breast cancer and they found that hair relaxing creams were a big risk factor. Not only that, there were studies, and you can Google them, studies right here in Ghana, which show that women who were using hair relaxers had increased estrogen levels, estradiol levels above those who were not using them. The same thing applied to hair dyes and skin lightening creams. And the idea was that when we go to sit under the hair relaxing and it starts burning our scalp, those are actually cuts in the skin, and they allow these chemicals, some of them are benzenes, phthalates, metals, they seep into our body, increase estrogen levels, and then over a period of a lifetime, increase the risk of breast cancer. So I felt like we can't discuss breast cancer awareness without letting our Black community be aware that apparently so-called perming our hair so we look straight like Caucasians would increase our risk for breast cancer. And I also wanted to, and that'll be the last thing I'll talk about. I wanted to show, I showed you this abnormal cell, which shows that the normal cancer cells are now changed. So these little things I put on there, because even as a doctor, I had a hard time understanding it. These are the estrogen receptors, estrogen, progesterone, HER2 receptors. And even though the HER2 is not good in sense of the fact that it influences, or they're all part of the reasons why somebody has cancer, in a way, when it comes to treatment, you can target the estrogen receptors with hormone therapy and the specific HER2 therapy. Okay, so Barbara said they're called estrogen disrupting chemicals. I'll let her give a comment again. So you know what? 85% of Black people, I'm going to call it Sakura. We have Sakura breast cancer. 85% of women with breast cancer would not have these receptors. Now, you would think, well, if you don't have them, that's good. Well, if you don't have them, they cannot be targeted. So they're aggressive, they're more difficult to control. It's sort of like having a dog with a leash. At least you can hold that dog, right? So if you have a dog without a leash, now you can't stop that dog. I'm just using that as an example. But we seem to have more aggressive cancers. And like I've told you, if you can examine the breast and you feel all those abnormalities, it's good. But what it means is that you are not at stage 0 anymore. You are at stage 2 or 3, or like the woman Dr. Intua presented, you are really at stage 4 and your risk of dying is 85%. So if there's one thing I want you to take from this webinar is the fact that let's all strive to find breast cancer at stage 0 so that no woman is dying from breast cancer. We don't know what causes cancer. We know there are risk factors, but if we can find them early and treat them, no woman should die from breast cancer. So I'm going to see if Dr. David is able to make some comments, and then we'll take as many questions as we can. Dr. Intua, thank you once again. There are 9 things in the chat room. Okay, Dr. Intua, Agnes Obing said great presentation.
Lydia, what the gates can buy?
Let's see, I have to mute somebody asking for the gate keys. Okay.
She's been muted.
Yes,
muted.
Okay, thank you. So Dr. Intua, the feedback is people are saying that you've done a great presentation and we really are super grateful. And Barbara said the thing in permine creams is called estrogen disrupting chemicals found in permine creams. And then Dr. Grace, I believe it's Dr. Grace Adolfo, she had a mention about, she said current data does not support the notion of stopping birth control pills just because of being age 35. In some women who biologically have high estrogen and heavy bleeding, the correct birth control pill is often used to modify the estrogen exposure. In addition, birth control pills have been proven to decrease uterine fat, uterine and ovarian cancer. So that the point is that the advice for women above age 35 has been modified. So if she's available to talk about it, I'll give her a moment. Dr. Adolfo? Maybe she wasn't expecting.
Hello.
Yes.
I just caught a little bit of it just as I walked up. So great presentation, Dr. Intua, and Dr. I love your props. Those are wonderful. But I made that comment because, you know, way back when we used to say things about if you were on a pill and you hit 35, you needed to go off. That's been changed a long time ago. So premenopausal breast cancer linked to OCPs, that's a little shaky. And like I said, in some cases, we actually use, I'm a gynecologist, obviously, do have to use pills. And I want to be very sure that sometimes we get a little flustered because our non-GYN colleagues might tell somebody to go off the pills just because they're 35. So the advice there, and I think Dr. Ensor had also alluded to the cigarette smoking. So yes, over 35 cigarette smoking, the risk of DVTs. That's a different story from when you use pills over 35 because somebody's hemorrhaging and getting a blood transfusion every month and things like that. And then we try to help them, and they say, well, my doctor told me to go off my pills. There are different kinds of pills. In fact, in those circumstances, I intentionally don't even say birth control pills. I explain to them this is hormonal control to modify your own innate hormones. And for some, and obviously, if your body makes a lot of, in a sense, high estrogen, you bleed more because the thickening of your uterine lining is very high every month, and that leads to a whole lot of other problems. So I thought the presentation was wonderful. I just wanted to modify that one piece of advice.
Okay, thank you so much, Dr. Grace. Dr. Grace Adolfo is a Hobson, right?
Yep.
She's a proud Hobson.
Very much so. So I don't talk to Wesley girls.
Oh, we're not. Those are artificial barriers. Artificial. She went to medical school here in the US, and she's an OBGYN extraordinaire. So thank you for, and oh, by the way, her mother built Martin de Porres Primary School. So she's impacted many lives. They just had their 50th anniversary. So thank you so much for that wonderful contribution. So kindly,
even having the forum, I think it's wonderful.
Yes, so kindly share your questions. In one day, I could think of 10 people I knew who had breast cancer. So if you know somebody who's had breast cancer, just do a hands up on the screen so we can see. And if you don't know anybody who's had breast cancer too, that's fine. I'm not putting Auntie Agnes on the spot, but she was one of the first to join. She's in the Richmond, Virginia area. She's a nurse. So I'm gonna ask her to say something. If she knows somebody who's had breast cancer, she said she came to get more knowledge to take care of her patients. You're muted, Auntie Agnes. Oh, we still can. I think she didn't unmute.
I'll mute. Can you hear me?
Yes,
okay.
We can.
Okay, I was going to say self-examine. I just wanted to say this. Self-examination is very, very important because I had 3 biopsies. 2 in my right breast and 1 in the left one, and I detected them myself, but luckily they were all benign. So we have to lay emphasis on people checking themselves and doing their breast exam. That's one thing. I had a lot of patients. I used to be a hospice nurse, so I had a lot of patients who died of breast cancer and other cancer, so many cancers. So I have people I know, yeah.
Okay, Dr. Jemima Kankam said, thank you very much, Auntie Agnes. Dr. Jemima Kankam says she doesn't know how to raise her hand, so I'm virtually raising it for her. Go ahead, Auntie Jemima.
Okay, there's a reason why I said it privately. Anyway, that was wonderful. That was wonderful. I have a friend who actually was very good at examining herself. She's a nurse, and she actually found a lump, went to her doctor, and the doctor couldn't find it. You know, the doctor examined her breast and said, oh, there's nothing there. Of course, you know, medical personnel are not always taken seriously. But she insisted and said, doctor, please come, put the doctor's hand on the lump. And long story short, it was breast cancer. She had the treatment, and it's over 5 years now, and she's doing well. So again, as Auntie Agnes said, self-examination for those of us who are not good at it.
Okay. Thank you so much. So thank you very much, Auntie Jemima. That's precious. Auntie Jemima is a wonderful 70-something-year-old doctor who, in her mind and in our mind, she's 30 for all we care, because she thinks like us and talks like us and interacts with us like that. Anyway, so Dr. Boafo wanted me to make an important comment that in Ghana and in a lot of educated women, people are smart until they get cancer. And then they decide that instead of following physicians' recommendations, they're going to go to prayer camps and use herbalists. And so I want to make the statement that a lot of Black women will have that 50% mortality in breast cancer, because instead of just following the convention, they will do everything but. In fact, when I was a student, over time, we could smell, Prof. Bedu taught us to learn the smell of breast cancer. So I could close my eyes, and if somebody with breast cancer came within 4 or 5 feet, I can say that this is breast. Why? Because the breast cancer would be coming out, the tumor would be coming out of the breast, and it has a distinct odor to it. You can diagnose it with your nose, just that. And people would come in so late, and we know that the horse is out of the barn, and it's going to be metastatic breast cancer. So let's all remember, even though at this point, my position is the self-breast examination is great, but if you're picking a tumor with self-breast exam, just know that you are not at stage 0 anymore. You are not even at stage 1 anymore. You're probably at stage 2, and stage 2 mortality is 15%. It's not 0 anymore. So unfortunately, I don't have much information on who pays for mammograms, but if you live outside the Ghana, or even if you don't live out, maybe as a group, we should start thinking, what can we do if we want to impact our generation to make sure that the 1 in 5 women who would get breast cancer, they're getting mammograms frequently and for free, just like their counterparts who live outside the nation. So that's what Dr. Boafo wanted me to mention. And Muriel had an interesting question. She said, would you advise anyone in their 30s to start doing mammograms? I would say if you can pay for it and you have risk factors, but according to the guidelines, normal, regular people, no family history, you should start at the age of 40. If you have risk factors, and there are specific ones, you have a first degree, like your mother had breast cancer. Your aunties, 3 out of 6 aunties had breast cancer. And you smoke, you're overweight, you don't exercise. Then you should be getting those mammograms at the age of 30, and even an MRI on top of that. Now, there's a gene that I don't want us to forget. It's called BRCA1 and 2. It's sort of similar to these receptor things I said. It's inside the cell, and it's almost like you are born with it. It's something that you inherit. These genes, I want you to remember, BRCA1 and 2 have been associated with breast and ovarian and even, I think, uterine cancer. In fact, for the ovaries, it is so bad that at age 40, you're almost 80% chance of of developing ovarian cancer. For breast cancer, if somebody does the genetic testing and it's positive for BRCA1 and 2, it's actually recommended. In fact, they've done a study. I was just reading a study in the New England Journal of Medicine that those women are advised to get bilateral mastectomy after they've had their babies and they know they don't need their breast anymore. And a good example is, I don't know if you remember this actress who was married to Brad Pitt, Jolene something.
Angela Jolie.
Angela Jolie, she had both breasts removed. So I'm almost certain that she tested and she had BRCA1 and 2, because it's better to live without your breasts than to know predictably that you would get breast cancer. So they studied, I think 78 women who had the gene and who did bilateral mastectomies and those who didn't. And then predictably, the bilateral mastectomy reduced the risk of breast cancer by over 90%. So if that facility exists and you can test BRCA1 and 2 greatly increases a woman. In fact, 10% of all breast cancers have that gene. And so if it's found, it's better you take both breasts off than to wonder if you should do a mammogram. So that was the answer to Muriel's question. And I think there was, Dr. David, I know you're driving. If you want to throw in an answer, please. Somebody says, Isabella says, are ultrasounds better in younger women with dense breast tissue than also, somebody's making a, doctor is, well, okay, I'm running all over. Ultrasounds are better in younger women with dense breast tissue, less than, okay, Isabella, please, it looks like you're not asking a question, you're giving us information. So kindly unmute and
what I was saying, hi, I'm listening from the UK. What I was saying was that I know that in younger women, mammograms are not, they tend to scan them more, an ultrasound, when they are less than 35, because the breast tissue is quite dense. So that's just a comment I wanted to throw in. Okay. And then just a quick question as well. How much is a mammogram in Ghana? And we haven't spoken about cost. We haven't spoken about cost at all. And I think that's so important.
Okay, I've spent the whole day making phone calls. I don't get an answer. I attended the HOPSA event, and so I ran into one Miss Ifia Apia, a breast cancer survivor, who said she's been raising money, or they've been getting hospitals to pay for, like, the whole month. Mammograms are free. So she's been doing that contract. And then there's one Miss Juliet Lutrot, who is also a breast cancer survivor. I was trying to get hold of them today to be able to find that answer. But what I have found is that, okay, Ida said it's 260 Ghana cedis. Yeah. So in reality, so that's about, let's bring it to dollars. So that's about maybe $30. Maybe one of the things we can all do as women, we can start a little fund to support. I know we can cover half of Ghana, obviously. She said it's 500 Ghana cedis. So we can't cover all of Ghana, but sometimes little things make a huge impact. Maybe we can say women who are at risk. And Miriam said it's 200 Ghana cedis at the 37 military hospital. Because I almost know for sure that it's not free. So if we're saying that this is what's going to save lives, maybe beyond raising funds, this is an area that we should approach the government and say that, you know what, you said we have national health insurance. Half of the people in Ghana are women, and one of the biggest cancers that are killing them is breast cancer. And if you can detect it at stage 0, there'll be 100% survival. You should cover this as an intervention. You know, instead of raising funds and skirting around the issue, maybe these are the things that women should advocate for in this country. So I think that answers the cost.
I think, Bertha, I just wanted to chip in here. Yeah, the mammogram in Ghana, depending on where you go, it's between, like it's been said, between 250 and 500. During October, some of them make it 250 or 300. And what you said is actually very important. It's the same with cervical cancer. You know, cervical cancer has been eliminated in Australia or somewhere like that. And it's because they were doing education, screening, and then treating. And you have to have a government that is willing to see this as something that is killing women. And so it has to be on the National Health Insurance Plan. And unfortunately, women's diseases, breast cancer, cervical cancer, are currently not on. For example, for cervical cancer, the government will pay 19 cedis for a provider to do a pap smear. How many providers will be willing to do a pap smear on a woman if they're going to only get 19 cedis from it? And so they are not doing it. Okay. 19 cedis, yeah. So they are not doing it. And so, like you're saying, this is probably something that we could even, well, maybe once this economic situation in Ghana calms down a little bit, we could do like a writing campaign. What do you call that thing even? We could do sign a petition, you know, for both of these things, because we can easily catch people at early stages. And even if they decide, because in London, in England, it was, I think, Isabella, is it only recently that it's been made every year, or it's still every 2 years for mammograms? You know, so even in some of the developed countries, it was every 2 years that people had. And so even if they decide that they would do it, and okay, start with even people who are at high risk, you know, at least we'll have a subset of our women being screened in this way. And that at least then that way the cancer can be caught early.
Yes.
I want to make a comment too that, you know, we did mention that, for example, in the US, they don't consider self-breast examination as, you know, something that people should be doing, actually. Some of the health organizations, they don't. But I say that in a place like Ghana or other resource poor countries, you know, it is better than nothing. And it is true that maybe sometimes when you find it, it may be stage 1, stage 2. But however, it is better than it not being seen and you end up being metastatic.
Right.
Stage 4.
Yeah, I would agree with that.
And so,
I don't know if you guys
so
can
that
hear
is
me.
why I encourage people to do self-breast exam. But like I said, let somebody who knows how to do it. And I'm sure Dr. Jemima's case that she said that even a physician missed it. It sometimes happens. For example, if somebody comes to me and says, I felt a lump, the first thing I do is to let her put her hand there so that when I come to that area, as I'm examining the breast, I see whether I can feel what they felt. And so with our people, because people cannot afford the mammograms, at least let's encourage each other to do that monthly breast exam if we are still menstruating. 1 week after your period is over, the breast is not tender. And if you are postmenopausal, you just choose a date like the 1st of every month or the 31st of every month, and you do your self-breast exam. If you can afford one of these enhanced devices, you can also get it and do your, after you've done your self-breast exam in a dark room, you stand in front of the mirror and use it on your breast, and you would see that the breast will look red as you point to different places. And if there's a mass, you'll see a shadow over there. So they are not very expensive, but they are something that, you know, people could get, especially if they are at high risk and cannot afford a yearly mammogram. Even if you do it every 2 years, then in between you do the self-breast exam. Every year you can go and see a doctor for a clinical breast exam. And that is important, because sometimes in Ghana, we only go and see the doctor when something is wrong.
When it's wrong.
Yes, but some of it, but you know, you are an informed patient when you go and say, I want to have my annual physical. I want to have my well woman exam. Can you please, can I make an appointment for that? And some of them will do it for you. Yeah, because they realize that. Thank you.
Right. Thank you. So Mrs. Emilia Latte has, and I'm going to let her ask her question. She's been waiting for a while. So Mrs. Emilia Latte, we're so honored to have you. We're glad that you joined us. She's an awesome lady who is, her daughter is a surgeon who trained in Ghana and is specializing in Germany. We're so happy to have you.
To say that.
Oh yes, you raised the daughter. You've done well.
My sweet sister Berta, thank you so much for this wonderful program. And it's a source of blessing. We've shared the link with a lot of women. And thank you so much for this insight. would
Right.
we wish we could have the recording so we could use it in church, like you said in your WhatsApp to us. So afterwards we want the recording so that we can use it in church. Yeah,
Yes.
my question is, well, a self-disclosure. And it's about 6 months ago, Doc, I just detected this water, a little slight coldness on my nipple, and I saw in my nightie. And so I got my husband to say, oh, this is just maybe some sweat. So it didn't appear again. And later on during the week, I was critical. And it came again on that same nipple that morning. It is when I've gotten up and I've just bowing, and then I felt it. So immediately, in fact, I didn't waste even 2 days. I went to the hospital, IMA, that is the Maritime Specialist Hospital. And I went through quickly, I did a mammogram and an ultrasound and waited for the specialist. And in fact, the doctor examined, was even pressing the nipple and nothing was coming. It looks as if I wasn't saying what I said. Look, I know what I'm about. A woman over 60 knows what I'm about. So he says, okay, that's okay. You see the specialist. So I saw the specialist when the report was ready. I read through the report. I forwarded it to my daughter, and finally the doctor said there's nothing scary. Everything is fine. It's a hormonal at age 60 plus. Of course, I said, doctor, it's not that I'm scared, but it is abnormal. He said, no, once a while you see it. I said, doctor, what is causing it? He said, from all your results and everything shows nothing, except that breast is indicating that there is a little dilation in the breast duct, a little, and that there's nothing that is fearful. So I went and said, he gave me some antibiotics and to see him after 3 months. And after 3 months, getting to 6 months now, went back again. And I see the water every morning when I get up in my nightie. And the doctor says, there is nothing. If you are scared, that we can just do a surgery. I said, doctor, you are a doctor. You've got to tell me, a layperson, something. And the doctor says, madam, there is nothing scary about you. Look, all your report and everything. I said, doctor, I don't like seeing this fluid-like thing in my nightie every morning, and once a while it comes, and when I put on my brassiere, sometimes you could see it in the white brassiere. I don't put on any color of brassiere apart from white. So at least you could see the stain that is a little yellowish. It's just on the nipple. And so, doc, this is what I've been told.
So you know, as you're talking, what immediately comes, and we can talk offline.
Yes, please.
What I'm sensing is you probably have galactorrhea, which is
Right.
breast milk coming out when it's not supposed to come out. And usually that's because a hormone called prolactin may either be acting or withdrawing. So the next step is to get prolactin levels, and also depending on the level, imaging studies of your head. So I think that there is something changing because so when a woman is pregnant, for example, the breast is engorged, but the milk doesn't come out. The minute the baby comes out, messages are sent to the brain, and then the breast interacts with this hormone called prolactin, and then breast milk starts pouring out. So for the breast milk to come out, there is some chemical imbalance. So we'll talk about it after the okay. So
Yes,
we'll
please.
see what tests you've done already. And then we will talk about, we'll get to the bottom of it by all means.
Yes, please. Thank you so much, sweet Beta. Okay, we'll talk offline.
Hey, Bertha, can you hear me?
All right.
This is David Osofo. Can you guys hear me?
Yes.
This is David Osofo. Can you guys hear me? Yeah,
Yes.
this is David.
Yes.
Yeah, okay. Barbara, Dr. Insua, thank you so much for your presentation. I listened to all of it. I'm not a woman, but I'm going to be going on Amazon to look for your book. There might be something in there for me.
Thanks.
And Bertha, thank you so much for great moderation of this meeting. Sorry I have issues getting on, but I'm here for any questions. If anyone has any questions for me.
David, we were just happy to know you were around. You know, you didn't have to say anything. It was just your aura and knowing that we had an oncologist and he was on the line. That was like plenty for us.
Besides being a married woman with 3 daughters, living with 4 women in my house, I never interrupt women when they're speaking.
You're good.
I know better.
So, Bertha,
Yes.
this is Dr. Adolfo,
Yes.
Philadelphia. So the lady that was talking about the possible galactorrhea, I'm not sure what other studies she's done, but I agree with you. Basically, you need a prolactin and thyroid level, and then and if that's how you're looking for imaging in the head. But I'm not sure whether she meant that she saw a breast surgeon, because sometimes things that have to do with the duct as opposed to the lobules can also cause an abnormal, nipple secretions.
Yeah.
So
Right.
in that case, the breast surgeon will actually explore the ducts. But the way she explained it, obviously, the prolactin and thyroid and pituitary imaging would probably be the first thing, and then seeing the breast surgeon.
And
All
she's
right.
probably preoccupied with breast symptoms. She might have neuro symptoms she's not even paying attention to.
Yeah,
Right.
that's right.
Right. And we'll ask her offline if it's bilateral, unilateral, etc.
Right.
So we'll connect her with all the doctors. So Auntie Emma, you're in the right place. We'll get you taken care of. And
of course. Thank you.
I said they will typically not do a mammogram on somebody who is pregnant. How effective is doing a self-breast exam while pregnant? So David, this is a good question for you. I'm assuming that if you're pregnant, the breast is gonna get engorged, but I'm sure breast cancer has been diagnosed in pregnant women, so.
Yes, it has. I've seen it before, and there's nothing wrong with doing that. And actually, to buttress one of Dr. Entwer's points, I know there are a lot of people in organizations who don't believe in self-breast exams here. If it doesn't add anything, at least it won't take anything away from you.
Right.
So I don't have a problem even here. Once a month, you pick a date, the 5th or whatever date of the month it is, for everyone to do their self-breast exam. And of course, a week or so after a menstrual period is the best time to do it. So I still don't have an issue with anyone doing self-breast exams. And yes, if you're pregnant and you have a suspicious lesion, definitely at that point it's not a screening mammogram, it's a diagnostic mammogram. So diagnostic mammographies are done every time.
Okay. All right.
Yeah,
David, that's wonderful. Auntie Grace, it looks like your hand is up again.
Oh no, that was before.
Okay.
I just wanted to also mention that the amount of radiation in a mammogram is very small anyway. So I have some patients who says, I don't want a mammogram because I don't want all that radiation. But I try to let them know that the amount of radiation that is in a mammogram is pretty small. And so like Dr. David said, you can do mammograms during pregnancy, and sometimes what happens is that if it's found to be suspicious, etc., as soon as the baby is delivered or so, then they will treat or whatever, right, Dr. David?
Yes, they will. And if you do, of course, with a lead shield, do a diagnostic mammogram, at that point, the next test you go to, whether it's equivocal or if it's inconclusive, it's an ultrasound.
Yes.
Which you don't worry about any amount of radiation exposure with an ultrasound. So there are ways to get around the problem.
Okay. So there is a question by Dr. Boafo, and I want to give a shout out to him and thank him for all the men in our lives. I called Dr. Boafo and I said, it's October. What should we do for breast cancer? And then he said, you know what? Let all the GPSF members go into their churches and give lectures. I said, how are we going to do that? Well, get somebody to create a generic set of slides and give it to everybody. And so I want to thank him for being such an engaged GPSF member and giving us all these ideas. So we're not just having this lecture because we wanted, it's because we had people like Dr. Kwame Boafo, who gave brilliant ideas, and he actually wrote up part of what I should tell the membership. I thought, well, these are good people to have in your boat. Anyway, so he has a question. What is the relationship between breastfeeding and breast cancer? And I'm going to use my powers as the moderator to try and answer part of it. And then I'll throw it to the oncologist and the presenter. So I showed you this, this cell here, which is the abnormal cell. And so whenever, these are estrogen receptors. The idea is that the longer over your lifetime you are exposed to estrogen, the higher your risk of breast cancer. So somebody who has never been pregnant, we call it in medicine, we say nulliparous woman, she's never had her menstrual cycles, her estrogen release and so forth, ever interrupted by 9 months of pregnancy. So if you have 10 children, you've had 90 months when your body wasn't exposed to estrogen. So your risk of breast cancer is lower. Somebody who has never had a baby was always menstruating, getting exposed to estrogen. So her risk of breast cancer is higher. Same thing with somebody who starts menstruating at the age of 9 or 8. Early menstrual cycles, menarche increases your risk. Late menopause, estrogen, intake of estrogen. So breastfeeding is supposed to be a period where you're not, in fact, when you breastfeed, you realize you're not getting your menstruation very well. In other words, you're not being exposed to estrogen. So the thought is that if you breastfeed, you decrease over your lifetime your exposure to estrogen, and so it decreases your risk of breast cancer. So that's my moderator response. Let's see if Dr.
Okay, I will add mine. They also think that lactation by itself makes the ductal cells very resistant to changes in cells leading to breast cancer. And so you have resistant cells being built up. And so because of lactation. And so they don't easily change and become abnormal. So those are two of the theories, what you said and this one, the fact that lactation makes the ductal cells and the other cells in the breast very resistant, but mostly in the ductal cells very resistant to change, which leads to breast cells changing.
Okay, so to use my little model that I made, it's almost as though you have this duct filled with normal cells, and instead of they getting plugged up, you've allowed it to be flushed constantly with breast milk. So now they're more resistant to cancer versus cells that have sat there for years and never had the advantage of breast milk going through them. That's just my moderator example. Dr. Barbara, that was good. Thank you. Okay, I think.
Yes, like lactation being protective is widely known and accepted. Now, the mechanisms of protection are some speculative, but yes, that's true.
Okay. See, I told you we're glad to have you around, the aura of an oncologist. Okay, so are there any, okay, oh, sorry, there's one more question. Somebody said, what is special about examining your breast at a specific day, which is that 1 week after menstruation? Why are we saying that's the specific time? And I think it was from
it's the density of the breast that changes with your menstrual cycle. But if Dr. Adolfo is still on, I'll defer that to her, the gynecologist.
I agree with you, Dr. David. It's that you're picking a time that it's not as dense and hard. So you should be able to feel any changes better. And, you know, the other comments about when a patient comes in and says they feel something and the doctor can't feel it, I agree with the other. There was a commentator, that another doctor, I think, that said, she always tells the patient, show me where you felt it. I think that's important. And the way I tell my patients is, you are familiar with your breast. The doctor's checking, 12,000 people. So you would be able to know that there's something on your breast that was different that you had never felt before. So, that way the patient doesn't feel that you're just, ignoring what she's saying. And I think is an important concept as well.
Okay, all right. So, but Tifu has come back. She's not happy with our response. She said, it looks like she wants to examine her breast every day. Is there, and then she's added that, what if the patient is not at childbearing age? Meaning, Tino, you know what, you're free to unmute and ask your question, you know, if you feel comfortable. One, you want to examine your breast every day, and two, you want to.
Yes, hello?
Yes.
Yeah, I was just wondering, I mean, we take shower every day. We have our breast with us every day.
Right.
What is the reason why for someone who is not at, say, 40 and above, you're not having kids anymore, do we still have to pick a date to do breast exam, or we can do it every day?
You can do it every day.
That every day. If you want to, yes.
Right. I think the idea of suggesting a particular day is to make sure that you're at least getting the minimum, you know. But if somebody wants to check every day, it won't hurt anything.
Okay. Thank you. I'm a nurse myself, just educating myself a little more.
I like Tina's question. She's saying, you know what, why have you made the self breast examination such a big thing? My breasts are with me every day. Why can't I touch it every day?
Yes,
yes, you may.
Why is taking my shower now a textbook thing I have to do? Anyway, that's funny. That was good. Anyway,
thank you all so much. This was very, very educational and informative for me. I've enjoyed it. I've really enjoyed it.
Oh, thank you. Thank you. Thank you. Thanks to Dr. Boaku and all the men who said, hey, let's do this. So Anne has a question which I'll ask before Phyllis, because Phyllis is a bit more complicated. Anne says, can you talk a bit about calcification and radial scars in the breast, and if it's important to have radial scars removed? I can give a comment about the calcification. I don't know what she means by radial scars, so I'm going to ask her to unmute and ask her question. But so when somebody, you remember I showed you that little tube with the stage 0 breast cancer? So mammograms are able to pick even the tiniest cancer, well, small cancers, even before it leaves the ducts. And it shows up as what they call microcalcification, or little calcium deposits. Based on the way technology is going, I'm sure in a few years, somebody will come up with an even better technology that can detect maybe breast cancer with a little blood test even before calcification show up. But that is what I know about calcification. I don't know what you meant by radial scars, whether it's because maybe you've had surgery. So please say I'll give you opportunity to speak, then all the experts would weigh in. That is if you feel comfortable speaking. Okay. If she doesn't.
Yeah. And the question about microcalcifications and calcifications is that also that rare instance where you can have a mammographically silent breast cancer. So if a woman feels a lump or their skin changes, and a mammogram is not diagnostic, doesn't show anything, that's the time to get more studies like an ultrasound and bilateral breast MRIs.
Okay.
You'll get insurance to cover. You get insurance to cover the cost of MRIs on a mammographically silent lump.
Okay. All right. Thank you. Thank you.
The other thing too about radial scars is that these are things that sometimes they are picked up on biopsy, and they believe they are benign, but then if they think it's there, they'll do a biopsy, and then they think that they are benign. That's what generally the idea is. But that's the deal with that. But then if they do see something like that, they want you to have a biopsy done. But they think that it's a benign lesion.
Okay. All right. So what about radial scars? I couldn't get on to talk. I don't know. I mean, I can understand what a radial scar, it goes from the nipple to the outside of the breast. but I can't imagine the context in which somebody will have a radial scar and why it needs to be removed.
Yeah,
Well,
hi, Ernest
Yeah,
here. Sorry,
that will go
a bit
back
of
to
noise in the
conventional
background.
method of
Okay, Anne is
diagnosis.
talking. Okay, Anne.
Yeah, sorry, I just wanted some clarification on it because I'd waited to have, so we did do a biopsy and it was benign, but I also asked to see a breast surgeon and, they advise that, it's better to just have it removed, because it could like maybe later on develop into something else, there's some percentage, like a small percentage, but it's probably best to just have it removed.
So what is a radial scar? What did you have a scar from a prior surgery?
No.
no.
I guess it's like a sclerosing scar. I'm not sure what it is, but I was just through like a normal mammogram, then I had to go in for an ultrasound, then a biopsy, and then they determined that okay, it was benign, but they still referred me to a breast surgeon.
Yeah.
Okay.
Betha, it is found on biopsy.
Okay.
They may see something like that on the mammogram, the diagnostic, then they would ask you to go for a biopsy. Most times they think that it is benign as compared to something like atypical hyperplasia. But then there is probably a small risk of breast cancer, they think. But most of the time they will just either do the biopsy and then may let you come back for other studies, in the course of time, whether it's every 6 months or so, and they will watch it and see.
Okay. All right. So Anne, at this point, are you at a point where you've been told to go and see someone and you haven't gone? Or have you gone and they're not sure?
Oh, I've been to see a breast surgeon, but unfortunately, so this has happened like over 2 pregnancies. So when they first detected I got pregnant, then I started seeing, I saw the breast surgeon when I was still breastfeeding. And then I followed up the following year after I had my mammogram, and I was pregnant again then. So it was like I just have to wait through another one before I get anything done.
Well, keep having those babies. Keep having those babies because you're decreasing your breast exposure to estrogen and decreasing your risk for breast cancer. Okay, so you have our information. If you want ours, you can keep track of it. Don't lose track, because I've heard too many people with breast cancer say, oh, they found something 3 years ago and they told me to go and check, but I wasn't feeling like, or I forgot or something. And now we know that breast cancer, it may be inevitable for some people, but it doesn't have to kill everyone. If you do the right things at the right time, we can together fight it very well. So Anne, that was a good question. If you want our information or want to reach somebody, we're happy to talk to you. And we've spent 2 hours. We actually started 18 minutes late, but I still wanted us to get to the top of the hour. So if you have some last minute questions, please ask it. But I want to tell you, this felt like we were having a cup of coffee, sitting in a big circle, because it was so sort of informal. We're just chatting, but getting stuff done. So thank you for everybody who chipped in. We have 2 more minutes.
In that case, I have a quick comment.
Oh, sure.
Unfortunately, one of the scariest things for an OBGYN is breast cancers that happen during pregnancy and are missed. Because when women are pregnant, their breasts tend to be full and nodular. And there are women that have died, because they were waiting for the pregnancy to be done and before they go and see to it. So it's important that if there is a question about it, and like the other, I think Dr. Dave had said, in those cases, the testing is diagnostic. So you cannot say, when there's something suspicious, you cannot say, well, gee, they're really thinking that there's a lump here and it's suspicious, but because I'm pregnant, I'm waiting. That has often led to trouble. And so one has to be very mindful of that. Because the problem is that it's just harder to see. And then if you went from one pregnancy to another, then basically it's an inconclusive mammogram that still has to be addressed.
Right. Okay. All right. And I want to remind everybody who's a physician here, please do examine your patients. If you come for me for travel clinic appointment, you're getting an exam. And sometimes patients will ask you, I mean, even my own family members have asked me before, but I came to you with my toe. Why are you examining my arm? And my answer is, look, you've come to me. I'm doing a full body exam. That's what I was trained to do. And I would never forget this. I was a resident working at Johns Hopkins, and I think I was on an infectious disease rotation. I was supposed to go and see somebody for a urine infection. Of course, the woman had broken her bone. She was there with a fracture in the surgical unit. And nobody had seen that this woman with a femoral fracture had an open breast cancer, because nobody was examining her breast. I asked the woman, she said she didn't know she had breast cancer. So I made a diagnosis of breast cancer in somebody in the surgical unit. It means so I'm just reminding all of us that if you're a physician, please take time to examine your patients. They're there, even if they come with, of course, you have to do sometimes exam focused, region focused exams to get things flowing. But if you have time, always examine your patients, fully. They travel to come and see you. Just give them the benefit of your medical knowledge. So on this note, I want to thank everyone. This was streaming on YouTube, so I will share the link, and please spread the word. I've enjoyed moderating, and thank you to Dr. Osapo and Dr. Barbara for availing themselves, and all the other presenters, Dr. Klankam, Dr. Grace, anybody who spoke and made us learn something. Even Auntie Emilia, who we're going to reach out to, she taught us something. She made us put our thinking caps on. So thank you very much. You all have a wonderful evening.
Beth, before we go, I just want to advise everybody, please get an annual exam every year. Go for that annual exam. You don't have to be sick. Just tell them that you are coming for your annual physical exam. Please, yes. They will examine you, and they will do your labs as well. So we can live long and fulfill our destinies that we've been given. Thank you.
Thank you.
Thank you.
Thank you so much, Doc. On behalf of everybody here in Ghana and everywhere, we say thank you so much. Oliver Twist, we want more. Bless your heart.